Welcome back to Ophthalmology for undergraduates and postgraduate beginners. Today we are going to discuss about the extraocular movements. How to check the extraocular movements? You have to take a torchlight, hold the torchlight about 40 centimeters from the patient's eyes and ask the patient to look at the torchlight. Then you have to move the torchlight in 9 directions and ask the patient to follow the light. You have to move the torchlight up, you have to move the torchlight down, you have to move the torchlight to the left, you have to move the torchlight to the right. Then you have to make a diagonal movement. You have to move the torchlight like this and come down like this. And you have to come back to the original position, then other diagonal position. You have to move in this direction and you have to come down like this. This way, all the 9 directions, the movements are checked. Extraocular movements can be broadly classified as uniocular movements or duction movements, binocular movements, which can be of two types. One is version movements, other is vergence movement. What is this version? When both the eyes move in the same direction, that is called as version. When both the eyes move in opposite direction, that is called as vergence. 9 directions of the movements of the eyeball are named as elevation, depression, abduction, adduction. You have dextro elevation, elevation towards the right side, dextro depression, depression towards the right side, levo elevation, elevation towards the left side, levo depression, depression towards the left side, and the primary positions. Now let us see what are the muscles involved in each direction of eye movements. For seeing on the outer side, that is the temporal side, the lateral rectus muscle acts. For seeing towards the medial side, medial rectus muscle acts. For looking up straight, the superior rectus muscle along with the inferior oblique muscle does the action. For looking down, the inferior rectus muscle along with the superior oblique muscle does the action. For looking temporal side and upwards, the superior rectus muscle is responsible. For looking on the temporal side and downwards, the inferior rectus muscle is responsible. For looking up and towards the nose, that is towards the medial side and upwards, the inferior oblique muscle is responsible. For looking towards the nose and downwards, the superior oblique muscle is responsible. For looking straight ahead, all the muscles should work in a coordination. Then only we can have a orthophoric eye position. If any one of the muscle is not functioning, what will happen? The muscle which is doing the opposite action will be acting unopposed and it will pull the eyeball towards it. Suppose there is a lateral rectus paralysis on the right eye. What will happen? The medial rectus muscle, which is of normal condition, will pull the eye towards the nasal side. So naturally, whenever there is a muscular paralysis, the eyeball will go in for a squint or strabismus. Let us see what are the types of strabismus. Whenever the muscles causing depression of the eyeball is paralyzed, it can be either inferior rectus or superior oblique. Due to the unopposed action of the superior rectus and inferior oblique, the eyeball will get deviated upwards. That is called as hypertropia. Whenever there is a paralysis of the muscles that cause elevation of the eyeball. Elevation of the eyeball, that is the superior rectus and inferior oblique muscle. Due to the unopposed action of the inferior rectus muscle and superior oblique muscle, the eyeball gets deviated downwards. That is called as hypotropia. Whenever there is a paralysis of the medial rectus muscle, due to the unopposed action of the lateral rectus muscle, the eyeball deviates outwards. That is called as exotropia. Whenever there is a paralysis of the lateral rectus muscle, the medial rectus muscle acts unopposed and pulls the eyeball towards the nose. That is called as esotropia. Everyone is aware that there are 3 cranial nerves involved in the movement of the eyeball. That is extraocular movements. The third cranial nerve or the oculomotor nerve has 2 divisions. That is the superior division and inferior division. The superior division supplies the levator palpebrae superioris muscle as well as the superior rectus. The inferior division supplies the medial rectus muscle, inferior rectus muscle, inferior oblique muscle and sphincter pupillae muscle. The fourth cranial nerve or the trochlear nerve supplies the superior oblique muscle. The sixth cranial nerve supplies the lateral rectus muscle. Already we have told about the mnemonic SO4 and LR6. What do you mean by that? Superior oblique is supplied by the fourth nerve. Lateral rectus muscle is supplied by the sixth nerve. All the other muscles are supplied by the third cranial nerve. Here I am going to tell an applied anatomy. Whenever you have paralysis of the levator palpebrae superioris muscle leading to a ptosis in one eye and absence of elevation of the eye. The eye is hypotropic. The squinting of the eye is downwards. You should suspect superior division of the third nerve paralysis. Usually, the superior division and inferior divisions are present in the orbital apex and in the orbit. If a patient is having only the LPS and superior rectus muscle paralysis, then it should be a superior division at fault. There is no other associated problems in the eye. If the patient is having paralysis of the medial rectus, inferior oblique and the pupil does not constrict, it is dilated, then the patient is having a fault in the inferior division of the oculomotor nerve. Whenever you have isolated superior division or inferior division problems, the problem is either a ischemic neuropathy or there is some lesion in the orbit that is affecting this particular division. When talking about the trochlear nerve, that is a fourth cranial nerve, this nerve has the longest intracranial course. This is the only nerve arising from the posterior aspect of the brainstem. Superior oblique muscle is the only muscle supplied by this nerve, and this nerve is most commonly affected in trauma to the skull. When talking about the abducer nerve or the sixth cranial nerve, one important thing you should know is bilateral sixth nerve paralysis leading to bilateral abduction deficit in both the eyes due to paralysis of the lateral rectus muscle is commonly due to increased intracranial tension. Increased intracranial tension leads to compression of the abducer nerve on its course through the petrous apex part of the skull. This is the false localizing sign in increased intracranial tension The patient may have papilledema also. What is papilledema? Papilledema is a passive non-inflammatory bilateral edema of the optic disc due to increased intracranial tension. Bilateral sixth nerve paralysis with papilledema is always an indication towards a increased intracranial tension. Whenever there is an abnormal eye movement or there is a paralysis of a extraocular muscle or the ocular motor nerves, that is the third, fourth and sixth cranial nerve paralysis, we can follow a simple rule to find out what is the problem and where is the problem. The first simple rule is mononeuropathy. What is mononeuropathy? One of the three nerves are affected or one of the divisions of the third nerve is affected. If only one nerve is affected, then it should be due to ischemia. It is a metabolic problem, diabetes, hypertension, or it may be due to a emboli causing ischemia of that particular nerve. Very common cause. Next is the post-viral infection. Some people have fever for 2 or 3 days followed by a mononeuropathy. That is also a cause for mononeuropathy. Post-vaccination. People taking measles vaccine, mumps vaccine, vaccine for other viral diseases. Following intake of this vaccine, patient may present with mononeuropathies. It may be due to a demyelination of the nerve or it may be due to a COVID vaccine leading to a vascular ischemia. Sometimes in trauma, a mononeuropathy can come. A classical example is superior oblique palsy in head injury, isolated superior oblique paralysis in head injuries. Next is aneurysms. Aneurysms commonly affect the third cranial nerve. If the aneurysm is going to cause a third nerve paralysis, how to differentiate a third nerve paralysis caused by aneurysm from a vascular third nerve paralysis? In vascular third nerve paralysis, most often pupil will be spared, pupillary reaction will be there. But in aneurysms, most of the time the pupil will be involved, pupillary reaction will not be there, pupillary reflex will not be there. Why in aneurysm pupil is commonly involved? The pupillary fibers are on the periphery of the third cranial nerve. When an aneurysm is pressing on the nerve, the first fibers to get affected are the pupillary fibers. The second rule is a polyneuropathy. That is, multiple nerves are affected. That is third, fourth and sixth. All of them are affected. One of the location for such a affection is cavernous sinus. Cavernous sinus thrombosis, cavernous sinus abscess can lead to third, fourth, sixth and fifth nerve first and second divisions. If you see all these problems or paralysis, then the lesion should be in the cavernous sinus and most of the time it may be unilateral. Sometimes in extreme cases it will go for bilateral problem. Next is the orbit. In the orbit, all the nerves can be affected due to a orbital cellulitis. Orbital cellulitis, you know that it is behind the septum. If there is inflammation beyond the septum of the lid, then it is called as orbital cellulitis. When the apex of the orbit is not affected, only the third, fourth and sixth nerve paralysis will be there. When the orbital apex is affected due to involvement by the orbital cellulitis or due to a orbital pseudotumor in the apex of the orbit. Apart from all the cranial nerves, that is the third, fourth, sixth and fifth nerve being affected, the second nerve will also be affected, leading to decreased vision or loss of vision. Third rule is patient may have a mononeuropathy or a polyneuropathy. Sometimes it will be associated with other systemic neurological deficits. Other systemic neurological deficits like hemiplegia, involuntary movements of the body. If they are involved, then the lesion should be in the brainstem. Let us see some examples for such a lesion where there is a mononeuropathy or polyneuropathy with associated systemic neurological deficits. As far as third nerve paralysis associated with systemic neurological deficit is concerned, there are 4 syndromes. One is Beaver Syndrome, where there is a ipsilateral third nerve paralysis with contralateral hemiparesis due to involvement of superior cerebral peduncle in the midbrain. Benedict syndrome is ipsilateral third nerve paralysis with contralateral extrapyramidal symptoms due to involvement of red nucleus in the midbrain. North-Nagle syndrome is ipsilateral third nerve paralysis with ipsilateral ataxia, the same side ataxia due to involvement of superior cerebellar peduncle. Claude syndrome is nothing but it is a combination of Benedict's and North-Nagle syndrome where there is a ipsilateral third nerve paralysis, contralateral extrapyramidal symptoms with ipsilateral ataxia. Here both red nucleus as well as superior cerebellar peduncle are involved. In the third rule, when we talk about a sixth nerve paralysis with the systemic neurological deficit, we have to consider about 3 syndromes. The first syndrome is Millard-Gubler syndrome, where there is a ipsilateral sixth nerve paralysis, ipsilateral seventh nerve paralysis as well as contralateral hemiparesis due to superior cerebral peduncle involvement. Next is a Raymond syndrome, where there is a ipsilateral sixth nerve paralysis with contralateral hemiparesis due to superior cerebral peduncle involvement. There is a difference between Millard-Gubler and Raymond syndrome. In Millard-Gubler syndrome, 7th nerve is affected. In Raymond syndrome, 7th nerve is not affected. When talking about the Fovili syndrome, there multiple things happen. One is the 5th nerve, 6th nerve, 7th nerve, 8th nerve are all affected, and due to involvement of oculosympathetic neuron, Horner syndrome will be present, and due to involvement of parapontine reticular formation, there will be a horizontal gaze paralysis. So when you are looking on the left side or right side, there will be a deficit, that is a horizontal gaze paralysis. Whenever there is a nuclear level lesion of the third nerve, we should look for bilateral ptosis because there is only one nucleus for both side LPS, and superior rectus muscle on the opposite side will also be having a weakness. So bilateral ptosis, bilateral superior rectus muscle paresis or paralysis, you should suspect a nuclear level third nerve paralysis. Fifth rule we have already discussed. Bilateral sixth nerve paralysis is commonly seen in increased intracranial tension because of the compression of the nerves over the petrous apex of the intracranial course. The sixth rule in diagnosing abnormal extraocular movements is its variability. The extraocular movements vary when you check one or more than one times. First time it may be full, the next time there may be a deficit. First time there may be one type of abnormal movement, next time there is another type of abnormal movement. This is a classical finding in myasthenia gravis. Myasthenia gravis is a disease of the neuromuscular junction, and this can be diagnosed by using a cold pack test, or you can do a tensilon test. The seventh rule in the diagnosis of abnormal extraocular movements is differentiating between a paralytic strabismus and restrictive strabismus. What is this restrictive strabismus? It is due to a mass or a swelling or a tumor or a fibrosis of a tissue preventing the movement of the eyeball. In differentiating these two, we must know about two things: primary deviation and secondary deviation. Primary deviation is a deviation when a normal eye fixes on an object. The deviation of the abnormal eye, that is a squinting eye, is the primary deviation. Secondary deviation is when the abnormal or squinting eye fixes on an object. How much of deviation the normal eye undergoes, that is the secondary deviation. In paralytic strabismus, secondary squint or deviation will be more than the primary deviation. In restrictive strabismus or squint, the secondary as well as the primary deviation will be the same. There will not be any change in restrictive strabismus or squint. There is a simple test to differentiate between a paralytic and restrictive squint, that is a forced reduction test or forced generation test. Extraocular movements is a very huge topic to be covered in a very short video. It is in itself a separate subject. Let us not get confused with so many things. Let us know the basics of examining the extraocular movements. With this, I will stop here. Let us see about the intraocular pressure examination in the next video. Thank you.